January 14th, 2020. Dr. Deuk with Deuk Spine Institute. And guys, how did the Mayo stand get over here again? Who moves this here? We're getting ready to do a Deuk laser disc repair. I'm getting ready to slash my wrist. Just an expression. Anyway, our patient is having a 2-level Deuk laser disc repair. This is a procedure where we go in and repair herniated discs in the lower back or neck. This patient has back pain and problems with their nerve going down into the leg. You want to go check that real quick? So they're having right-sided symptoms. No, it's okay. I can't answer that right now. All right, how is the Mayo stand getting outside the door again? A mouse shouldn't fart in this building without you knowing about it. All right. Now our patient has 2 bad discs, herniations in the lower back, and we need to fix the disc if we want to get rid of her back pain and her leg symptoms. So she has a few choices. One is fusion surgery. We could fuse those discs, probably get rid of most of the back pain if it's done well, but it's a major surgery, very painful, long recovery, and high risk of complications. So instead, the patient chose to have the disc repaired. And the only disc repair available in the world right now is Deuk laser disc repair. Good afternoon.
Hi.
This is Dr. Deuk and I'm right here behind you. That's my hand on your back, okay?
Yeah, I recognize your voice.
All right, good. Well, you're going to be awake like we talked about for a little bit.
Okay.
And then we're going to put you to sleep when it's safe and you've done helping me, get to where we need to be. The first thing you're going to feel is a little poke and some burning. That's just me putting some numbing medicine, okay?
Okay.
And actually before that, you'll feel my hand poking around, just prodding, trying to feel for the right spot to go in.
Okay.
If you feel discomfort or pain, just say ouch.
Okay.
And I'll go ahead and help you out with that, either some more medicine or moving things around. But try not to get off the bed.
Oh, I won't.
Yeah, the most important thing is lay still and just say ouch, and then I'll do something to help out, okay?
Okay.
All right, so this is my hand. I'm just feeling around. I'm feeling for the iliac crest. So since we're going to L5S1, we're going to have to go as low as possible. We want to know where the iliac crest is. How's our blood pressure? Good. We could probably bring it down a little bit. Now did you have sacroiliac joint fusions done?
Yes, I did.
Who did that for you?
Dr. Rudolph in New Hampshire. Ooh.
Sorry about that. That's that little stick and burn I told you about.
Yeah, he's in New Hampshire. And
Did that help you?
yeah.
So you had a lot of SI joint pain?
Oh, it was going down my buttock and legs and around my groin, and it felt like I was doing a constant stretching exercise.
How did they diagnose sacroiliac joint pain?
Very hard to do. It's kind of hard for them to diagnose that except for the symptoms.
Yeah, did they do a block?
What's that?
Did they numb up your SI joint?
I don't know.
That's typically what we do.
Oh,
We treat SI joint dysfunction all the time.
I didn't know that, but the problem was I was working at Woodstock and the insurance companies didn't pay for it, so after I got
The insurance company wouldn't pay for it, so after you got on Medicare, you went up north to New Hampshire?
I was up there for the summer.
Shot? Yeah,
I was up there for the summer, and I thought, well, around family, it's a good time to get it done. Ooh.
it's a good idea, Shot.
Yeah.
All right. Well, I personally don't do the fusions of the SI joint. I found that it's not necessary most of the time.
Mine worked really well.
That's great. You don't hear a lot of people where it works really well.
It's so hard for me to take any walks anymore.
I need a lateral. So I'm going to be talking to you, but I'll also be talking to my team.
Okay.
Okay?
Okay.
And like I said, once I've gotten everything where it needs to be, I'm going to put you to sleep, and when you wake up, we'll be done.
Okay.
But until then, you're going to hear me talking probably a lot.
Okay.
All right. So we're using an x-ray machine, shot, to get down to where we need to go.
All right.
Shot.
My head adjusting.
And I can see your metal implants down at your sacrum.
Okay, here there's 3 on each side.
Yeah, I see that. Shot. Just don't know that I can reach where I need to go unless I go a little bit higher. Let me try something else here. Shot. That's better. So let's see what we can do with the fluoro. I'm not entirely happy with that picture. I think we can do a little bit better at L5. I think we're 2 or 3 degrees off. So let's try wagging one way or the other. Let's bring the collimator a little bit more together. I don't know, I think that's worse. What do you think? Why don't you release the wag? Yeah, go ahead and do it the other direction. And shot. That's definitely better. That's definitely better. Let's, but I need you to move the whole fluoro south. Okay? And then you're going to need to bring my side, whatever you did, to wag it properly. Shot. All right, that's nice. What do you think, Luis? Yeah? Can we do better? Let's try wagging. And I think we need to do something with this, the plane. I think my side down a little bit, maybe. We're looking too much down the facet joint. We shouldn't be. That's better. That's definitely better. All right. Go ahead and lock that in. Let's see what we can do here. Shot. Shot. Where do you feel that?
Where you stuck it?
Okay.
Wherever that.
Shot.
Top of my buttock and back.
Yeah. We're right near your facet joint. Makes sense. Shot. Everything's going really well, by the way.
Okay.
Just so you know. I'll let you know if there's any problems.
All right.
I don't expect any at all. But this is the worst part for you, the patient,
Okay.
because you're awake.
That's this long needles I saw suggested.
Oh boy, you have to mention that?
Yes.
The answer is yes. Yeah, but I don't want you thinking about that. It's only going to make you tighten your back up more.
Really?
All right, yeah.
But they're very thin.
Like what? Acupuncture? Not quite. All right, AP. I think we're just caught up at the facet joint. Let's just see. You're doing really good, by the way. We can see all your metal that's in there from your SI fusion. All right, so yeah, I need to get a little bit over more.
Well, that doctor was also a teaching doctor, so
He's a what kind of doctor?
taught other doctors how to do that up there. So
Shot. All right, lateral. Was the surgeon orthopedic?
yes,
Does he do a lot of those procedures?
yes, he did. A lot of doctors he trained.
But we're still having trouble there. Give me a wag. Give me the wag. Shot. 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 I think that's just worse. Shot. That's probably going to be as good as we get it right there. Lock it down. All right, so our trajectory is not bad. Where do you feel that, dear?
Right where you were pressing. Oh.
Shot? 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 Shot?
It's going down my buttock and
Where do you feel that, Shot?
where you going, where you're sticking it.
I'm sorry?
Where you're sticking it and down my buttock.
All right. Just down the buttock?
And some down the leg too.
How far down?
I can't tell. Maybe do it again.
Shot?
Looks like it's almost to where the knee is. Half of
Yeah.
the side.
That's typical. We call it referred pain. Go ahead and give me an AP. So we got the first one done. It's the hardest one.
Okay.
The next one should not be as difficult, so don't get any ideas to make it difficult.
Okay.
Okay? Go ahead. Nice. I like it. Go back to... Actually, stay with AP for a minute. So far, we lost a drop of blood. How does that make you feel?
You lost the drop.
One drop.
Yeah, I don't see no.
It's pretty good, huh?
Yeah.
You worked at which hospital? Wusthof?
I worked at Woodstock.
Where did you work at Wusthof?
Central Supply, Central Service.
Which Wusthof?
Rockland.
So you know I was on staff at Rockledge for a while.
Were you?
Yeah, back in 2004, 2005.
Oh, I was there.
Yeah, I was the one of the neurosurgeons besides Dr. Matuk.
Yes.
I mean, I was the only real neurosurgeon there.
Yes, I heard Bill.
Relax. Huh?
I don't know about that before, but
I know about Dr. Matuk. He's not a real doctor.
I've heard a few things.
Lock it. Any doctor that puts insurance company payments to themselves ahead of patient care is not a real doctor in my book. They may have a degree, they may have gone to residency,
Yeah.
but they're not a real doctor.
His wife was
Shot.
pathologist.
She's a nephrologist?
A pathology.
Oh, pathologist?
She's in the pathology, yes.
I'm not surprised. When your husband has so much pathology, it's not a bad field to be in. All right, AP. But I had some not so good experiences when I went there to do my work. I remember the first brain surgery I got called in to do, they didn't have any of the equipment I needed. And I don't think it was your fault. They had like a giggly saw. We were joking about that the other day. Yeah, having to open someone's skull using a little like braided wire.
Wow.
Yeah, rather than the appropriate saw. You know, like a Midas Rex or something like that, lateral. Huh?
They sold it to HMA and doctors reported them that showed 60 minutes.
I heard they sold the HMA and then what happened?
The doctors were on 60 minutes. They complained about them because they were seemed like they were forcing them to do tests that they didn't even do. And
Where'd you feel that?
kind of sweating from breathing word.
What is your biggest problem? Is it back pain or leg symptoms?
Leg, butt, sticky word.
How about back?
Today my back was hurting. It's like
Not today, but in general.
my back, I seem to have it mostly at the top of my buttocks, and
So you do have daily back pain.
I have been having more back pain lately.
All right, we're gonna fix that for you.
Okay.
Are you comfortable?
Yeah. Uh-huh.
Is that the pain you typically get?
Yeah, but not that strong.
Right, but that's the location.
Yeah.
All right,
Most of it's my right side.
on a scale of 1 to 10, how bad is that pain there?
Well, that pain was pretty high, like a 10.
A 10. 10 out of 10 at L45. So
10?
we found one of your painful discs, that's L45, which we expected, and we just tested it with a discogram, and now we're going to have to do the other one. I let the cat out of the bag. I shouldn't have said anything. Shame on me. I'm sorry. Is that your typical back pain? Again. Right, but that's the right location. Yeah. And how high did that go? AP? No, how high did the pain go? Scale of 1 to 10. What was the highest it went? That's fine. Short time 10 is what we're looking for. So the good news is the 2 discs that we talked about fixing, they're causing your typical back pain. And when you wake up, we'll be done, and that pain will be gone forever, as long as you don't do something to make it come back, which you won't. So at this point, I need you to count from 1 to 100 out loud.
Ready?
Go for it. 100, 99, 98, 99, 95, 96, 95. That's like you. Louise, don't put the mayo stand right outside the door, and then I come back and the mayo stand's right outside the door. Count from 1 to 100. She counts backwards from 100 to 1. That's just like Luis. Luis works for me. He has the same problem sometimes. I'm joking with Luis. Luis knows that. I'm roasting him. My kids call it roasting. I'm roasting Luis. But if you don't roast people, they don't really change all the time the way they're supposed to. So you got to motivate them a little bit. I got to give Luis a hard time. Right? And now here you are experiencing it for yourself. You thought Luis was a lady? I don't know. Is something you want to tell us, Luis? I mean, he may be a lady, but he's got a beard. I've never checked. What? Here's yeah. Yeah, it's that minoxidil that he takes. Shot? All right, you're doing great. Just relax and lay still. It's going to be over before you know it. All right, so listen, people wonder, my God, you're joking around doing surgery. Are you crazy? No, I'm not crazy. I'm just very comfortable with what I do to the point that we can joke around. Everything's going well. The patient's doing fantastic. Her blood pressure's a little higher than I want it, but our anesthesiologist will lower it now and get it back in the range I need it. Let's try to get it under 110 systolic, please. I understood. So just before I put the dilator in, you guys could see there was a herniation at L5S1, and you can see the dye go around the herniation, kind of outline it back posteriorly, but you could also see the annular tear, the tear where the herniation came out of. Yeah, this is the most painful part for her, so we do need her a little bit light, a little bit deeper. I'll pull back just for a second so it's not hurting. Shot. Yep. So right at the tip of that dilator, you can actually see a gray shadow of a herniation coming towards the dilator and passing the tip. Pull the guide wire back a little bit. Shot. All right, let me know when I can proceed. Perfect. So this is the worst part for the patient, because I told you the annular tear hurts, and that's what's hurting this lady, is the annular tear. It's inflamed, thus in pain. Inflammation causes pain. Every doctor knows that. Every good doctor knows that. Those that choose to ignore it, I can't speak for them. But we tend to ignore inflammation quite often, unfortunately, in our patients when we should be paying attention to it. Shot? Yeah. All right. Inflammation is really the basis of pain. There are some exceptions, like post-herpetic neuralgia, trigeminal neuralgia. Some of the neuropathic pains are not inflammatory, but back pain is inflammatory. It's not neuropathic. It's not due to an abnormality of the nerves and their function. Shot? It's due to inflammation going on inside the disc or inflammation inside the facet joints. Do you want me to stop for a little bit, or? Is her IV working or not?
Yes, it is.
Lay still. Everything's okay.
Better, Mike, can you assist can you check if he needs something? The sociologist? Yeah, check if that is. I'll give it a buzz.
You have the infuser, right?
Yeah, but I just gave her a little bit.
That's fine. We'll just wait a minute. This is going to be the most stimulating part for the patient, going through the annulus, through the tear. That's where all the pain is emanating from. So it's kind of like if you have a pimple on your nose, someone taking their finger and just pushing down on the pimple. It really hurts. A lot more than normal. Obviously, pimples are infected, but this disc problem we're dealing with is not an infection in the disc, it's just inflammation. There are many non-infectious causes of inflammation in the human body. The annular tear is a source of inflammation that's not infectious. There's no bacteria, virus, fungus, or protozoan associated with it. It's just the body attacking the herniation, basically, trying to get rid of it. Shot. All right. So she was squirming around a little bit. It's okay. We still love her. Shot. And we're going to fix her disc, despite the fact that she was trying to make it difficult. Okay, let's get the fluoro out. You can see the tubular retractor is down inside the disc based on the lateral x-ray. And you can see all the fusion hardware that she had done for her sacroiliac joint fusion, which I did not do. Dr. I think she said New Hampshire did it. Dr. Rudolph.
Scope on, please.
As a matter of fact, I personally don't do SI joint fusions because I rarely find the need for them. Most patients with sacroiliac joint pain can be fixed with the proper therapy and interventional procedure where you do an injection in the joint. Stem cells, PRP, into the SI joint. So they don't need fusion, but some patients do. My brother, on the other hand, he's a neurosurgeon who does do SI joint fusions. I just find that I like to treat patients non-surgically if possible. Laser. How's she doing? Is she okay? So the laser is the blue fiber, for those of you who don't know. In the middle of the blue fiber, the blue is actually a protective plastic coating around the laser fiber. Inside is a little glass I don't really know, cable, glass tube, but it's not really a tube. The laser itself transmits energy from a machine that generates the laser impulse. The machine is at the foot of the table. It's being operated by Mike, who's a technician. And what is that? I guess off the bag, right?
Yes.
So this is all basically scar tissue from the herniation where the inflammation has been occurring. And the pedal is moving away. Um, the scar tissue doesn't really stain with a blue dye. Only the nucleus pulposus does. So the parts of the herniation that don't have a lot of nucleus pulposus aren't going to have a lot of blue dye. The parts that have more nucleus are going to have more blue dye. We know we're in the right spot. We did a discogram. You could see the outline of the disc. It's pretty degenerated. You can see the thin layer of dye within the disc, and you can see that dye coming out the back of the disc. Where's our fluoro picture? Good. Thank you. A lot of inflammatory tissue. And believe it or not, it's actually the inflammatory tissue, the pink stuff, that causes all the pain for the patient. The red stuff is blood. The pink stuff is granulation tissue. And this is really scarred up here, indicating chronic inflammation. This is all chronic inflammation right here, the golden stuff I'm working on. This is inside the disc, inside the annular tear specifically. You don't want to forget the lateral stuff. Some epidural fat. Pipe. So we're almost done with L5S1. We still have L45 to do. I usually start at L5S1 pretty much every single case, if they have L5S1 that needs to be treated, if they, the patient, does. So if I'm doing L45, L5S1, I start at L5S1. I usually start at the lower disc of the disc that I'm going to be doing, just to kind of keep things ordered. That's pretty much it. Just about done here. So this is what I would call a robust inflammatory response to the herniation. So robust that it's over the time it's pretty much removed the nucleus material, and it's basically just replaced it with scar tissue. And that scar tissue inside the annulus is where the inflammation has been going on, smoldering for a long time. This needs to be removed. Call it an annular debridement. Just about done. All right. All right. Laser off.
Lights on, please.
Scope off. Take. Okay. We did the L5S1. We're going to apply some pressure. Just the paraspinous muscles. I don't want any venous ooze or bleeding. And then we're gonna do the last disc, which will be L45. As a matter of fact, it'll be the last disc of the day.
We need fluoro on that TV.
Bring fluoro in, please. We have about 15 minutes. Shot. Shot. Nice job, Luis, by the way. So we're going to go through the same exact incision. So there's not two incisions made because there's two discs treated. We're going through one incision. We're going to push down through the muscles and dilate the muscle. Shot. We're going to hit that annular tear and we're going to go right through it. So we're going to enter the disc through a part that's already damaged. That's the beauty of this surgical approach, transforaminal approach. No, come on. Is that you don't damage the disc in a normal place. When you enter it, you go through the torn area and the herniation. Shot. Shot. Now let's see if this is just as fibrous as the last one. The last one was remarkably fibrous. Fibrous means scar tissue. Shot. Jordan, hello. Shot. So it's advancing the dilator. Shot, which we don't want to do. Shot. Shot. Good. Shot. That's it. Done. Scope out. Thank you. So we're inside the disc once again. And the last disc was extremely fibrous. A lot of scar tissue, all that white stuff. Very little herniation of disc nucleus left. Let's see what this one looks like. I suspect it'll be similar because I'm getting a lot of pushback pressure from the actual disc itself. Shot. Sorry, scope on. So there's more nucleus at this one. We get a lot of healthcare providers that come to Deuk Spine Institute from around the world. because they recognize the quality of care they get at Deuk Spine is second to none anywhere else, even hospitals, specifically for spine care. They also recognize that this surgery can't be done anywhere else in the world. It's done here, and it's so advanced and modern and minimally invasive that this is what people want for themselves. They don't want to be down for long, white tip. They want to be in and out and back to a normal life as quickly as possible. The Deuk laser disc repair is just that surgery. It offers patients very quick recovery, usually an hour. They can't drive a car the same day, but you can drive the next day, go back to work the next day. And it's in place of fusion, artificial disc. So if you've been told you need an artificial disc, mechanical disc, if you've been told you need a spinal fusion, if you've been told you need a laminectomy or discectomy, before you have it done, see whether or not Deuk laser disc repair is a better option for you. If you've been recommended for fusion, most likely you can have Deuk laser disc repair instead. Alright, so we're just debriding the annular tear and the herniation right now using the laser. As I was saying earlier, the laser fiber transmits laser energy from the laser machine, which generates a laser impulse down by the patient's feet. And it's a big machine. It looks like a suitcase that you would take on a trip to Africa or something. You know, if you're going on a safari. It's huge. Anyway, it's on wheels, and it generates a tremendous amount of energy through laser energy that's transmitted down this fiber right to the tip. And I have people asking me, aren't you worried that the laser is going to shoot around everywhere and zap people in the OR, and Chewbacca will show up and Princess Leia with her lightsaber? The answer is no, because the energy that leaves the tip of the laser only travels 0.5 millimeter before it's completely dispersed and gone, basically. So it can't do any damage definitely past 1 millimeter, but usually not past 0.5 millimeter. So you don't need to worry about it damaging something it's not supposed to damage. How is she? Let's try to keep her blood pressure nice and low for me to finish and get her recovered. So I think our first two patients, they're already gone. I talked to the first patient. He was a 3-level with a rhizotomy. His pain was pretty much gone in his back. He had no back pain. And his leg pain was gone. He still had some numbness in the leg, which is normal. It takes 3 to 6 months for that to go away. He had a little bit of nausea, which we treated with some nausea medicine, and he did fine. He's already gone. And the second patient is already gone as well. He was the 2-level that we just did. Left side L45, L5S1. The one with the extra disc in the sacrum. Anyway, he was doing really well. He was very happy. So we just have this patient to finish, which will be done in about 5 minutes, and then recover. And we'll be done for the day. If you have a question for me about spine surgery, spine problems, anything related to the spine, if you have a question about healthcare, insurance companies, healthcare policy, healthcare economics, healthcare administration, anything in healthcare, you're welcome to ask me. I don't talk much about my credentials, but I've served as the Secretary Treasurer of the Brevard County Medical Society for a year. I was then the vice president of the Brevard County Medical Society, and ultimately I served a year term as the president of the Brevard County Medical Society. I also served as chief of surgery at the hospital for 2 years. I served as chief of staff of the hospital, which is the highest position of the medical staff that advises the president, CEO, as well as the board members, and acts as the representative for the doctors to the administration and the medical executive committee. I've served on the medical executive committee for several years at the hospital. That's just to name a few things that I've done. Also, I'm the founder, CEO of Deuk Spine Institute, the medical director of Deuk Spine Institute, and I can tell you all about any of those healthcare topics you want to know about. But the purpose of these broadcasts is for education. We're here to educate the public, whether it's the lay public, whether it's medical staff, doctors, nurses, therapists, whatever. We're here to answer your questions. We're here to teach you. Shoot, we could even do some anesthesia questions. I'm sure anesthesiologists wouldn't mind answering a few. So feel free to ask while you can. You're getting free advice, free consultation, free what? Education? Isn't that what it is? People love things for free. So there's the tear once again. Very, very densely scarred, but you can still see it nonetheless. Just like the other level we did.
We have a question.
Yes.
One viewer says I had C3, C4, C4, and C5 fused and a plate put into my neck. I'm still having pain in my cervical spine. What could that be caused by?
Yeah, so one of our viewers says, hey, I had a cervical fusion, C3-4, C4-5, and a metal plate. Why do I still have pain in my neck? What could be causing it? So I'm going to tell you, first of all, I don't know why you're having pain because I don't have the benefit of examining you. I don't have the benefit of your films. But if I were to go based on my extensive experience, I would say the number one most likely reason you're having pain, assuming that the surgery is good, is that you have what's called facet disease. In other words, you're having pain coming from the facet, F-A-C-E-T, joints, either above your fusion, below your fusion, or both. So if I had to bet, that's what I would bet you have going on. The chance that that's what's going on is probably 80%. I could diagnose it for you, but I would need some imaging. I would need your X-ray, MRI, possibly a CAT scan, and I need to see you and do a consultation. We can do that over the internet for free. I could review your MRI for free. But whatever is causing your pain is fixable, and it shouldn't be hurting you. There shouldn't be pain. Okay, so the fact that there is pain tells me either there's something wrong with the fusion or there's a problem above or below your fusion. But there's definitely something going on that's fixable and shouldn't be happening. People who have good spine surgery shouldn't have pain afterwards. So most surgeons will tell you differently. They'll tell you it's normal to have pain, but it's not normal to have pain. If it was normal to have pain, you would have lived your whole life in pain. Okay, you'd be born with pain. Pain is not normal. So don't believe people when they tell you having pain is normal. That's bullshit. Either they don't know how to fix it or they don't want to fix it. One or the other. And Deuk Spine Institute, that's what we specialize in. We fix pain. So that's why we broadcast, is I don't want to see people living in pain. Okay? So whatever is causing your neck pain, I can diagnose it and I can fix it for you here. I'm happy to do the diagnosis part for free. You're welcome to take me up on that. And we offer that to anybody in the world. Free evaluation. We're not going to do your MRI for free. We'll read it for free if you've already got one. We're not going to do your CAT scan for free. We can't pay for your CAT scan to be done, but we can review it with you, and we can let you know if we think what the problem is. Clearly you have a problem. We just need to figure out what's causing it. And that's pretty easy to do. But I do need some tests. And I need to see your face and talk to you. And I need you to point your finger right where the pain's coming from. So, I suspect the pain gets worse when you rotate your head side to side. I suspect the pain gets worse when you look up at the ceiling. And if that's the case, it's most likely your facet joints. But I can't rule out the fact that you might have a broken plate, broken screw, failed fusion, infection. There's a lot of other things that cause neck pain after neck surgery. They're pretty rare. Fractures can occur, infections can occur, you know, malalignment of the spine, muscle spasms if you didn't do the therapy. A lot of people don't do the physiotherapy after spine surgery. That's a bad choice. You need the physical therapy. The physical therapy fixes the muscles, which have been weak and deconditioned, and they can cause pain when they're weak and deconditioned. They frequently do. They cause muscle spasms. So if you don't get those muscles addressed after your spine surgery, you're going to end up in pain. So there's a checklist of things that I would go over with you to figure out which one of them, or a couple of them, or 3 of them are causing your pain. But I can promise you it's fixable about 98% of the time. Look at the metal, melted metal at the base there, just by the laser. For those of you wondering, we got no water, no irrigation? Are we good? Did you change over? Huh? Thanks. Just say changing, so I'm prepared for it. But look at the laser blasts on that metal. Completely melted. And we're not even turning this laser up, by the way, folks. We've got it at 30, right? This thing goes up to 100. So, yeah. That's why when you talk to doctors who say lasers, they're useless, that's because the doctor's actually useless. And they're telling you the laser's useless. They're describing themselves. All right. What was the question?
We have another viewer asking, can this kind of procedure be done on the spine if someone has severe scoliosis?
Can this procedure be done on the spine of a patient with severe scoliosis? Great question. Yeah, the more scoliosis, the harder it gets. So at some point, I probably wouldn't be able to do it. I don't know how severe your scoliosis is, but I would say if you have a curve up to 45 degrees, 45-degree curve is pretty bad. I could probably get it up to 45, but if you're beyond 45 degrees, it may be too much. I can tell you, though, if you let me see your films and you let me see your MRI and your X-ray, I can tell you if it'll work. And if it's really, really, really bad, I would have to tell you no. But I would say I can do this on about 95% of scoliosis. So if you have scoliosis, there's a 95% chance I can do this surgery and fix your pain with this surgery and no other surgery. No fusion, no metal, no correction of scoliosis. Of course, this surgery won't correct your scoliosis deformity. In other words, you'll still be twisted, but your pain should be gone. We use this surgery to fix scoliosis pain all the time. All right, just about done. There's probably the last of the tear. Remember, we're doing the annular debridement now. I probably do need 5 more minutes at this point. I lied earlier when I said 5 minutes. I was a little, I don't know what you call it, premature. I mean, I wasn't premature with respect to my birth, but I was premature with respect to my expectation that we'd be done.
We have another question.
Yes.
One viewer asks, I get consistent lower back pain and an almost tingling pain at the very bottom of my spine. What could be causing this?
So we have a viewer who's saying I have back pain with tingling at the bottom of my spine. What could be causing it? Yeah, so there's a list of things that could be causing it. We have to go down the list. The first and most likely cause given, a normal history and normal epidemiology of back pain without any history of trauma or a surgery. So in other words, what I'm saying is I assume you haven't had back surgery. I assume you haven't had a fall with trauma. Because if you've had a fall recently, that would change my differential diagnosis in terms of the order and the likelihood of one cause versus another. It wouldn't change the absolute list of causes. However, the likelihood of each cause depends on the patient's history. So if you told me you fell out of a car last week and landed on your tailbone, all right, now we got a few things that it could be. But if you're saying I didn't do anything, I'm just getting back pain, the most likely cause, about 80% of back pain is going to be due to facet, F-A-C-E-T, facet joint syndrome, facet disease. So facet pain. Pain from a facet joint that has inflammation in it. You can look it up on the internet. It's called facet joint dysfunction. There aren't many places that fix it properly. There's a lot of people that advertise to fix it, but they don't. Deuk Spine Institute, we have probably the best technology in the world for facet joint pain. But that would be my number one. Number two would be a herniated disc, which is what we're fixing right now with a laser. Number three would be a coccyx problem with your little tailbone. Maybe it's inflamed ligament, coccygeal ligament. Another would be sacroiliitis. Another would be piriformis, Piriformis syndrome, where you tear a muscle in your butt cheek. It can definitely cause those symptoms. Another would be a fracture of your sacrum or of your vertebrae, like L5. Okay? Another could be, there could be other things like weird things like kidney problems, ureter, kidney stones. There could be pelvic disease like problems with ovarian cysts or fibroids. I mean, there's lots and lots and lots of things. I've got to examine you to really be able to tell what I think it is. And that comes, we can do that for free over the internet with Skype. You just have to go to the Deuk Spine Institute app and request a video conference with Dr. Deuk Majin. That's me. And I do them for free. As a matter of fact, we have a whole bunch of them on Friday morning. And we don't charge anybody anything for them. They're basically a free consultation for 10 minutes. I should say, not say 15, but for 10 minutes. And if you have an MRI, send it ahead of time so I can look at it and figure out what's wrong ahead of time, at least partially. And then we can do a nice 10-minute conversation. I can go over your MRI with you. That would be my advice. The MRI review is free. The consultation's free. So why not take advantage of a free second opinion or third opinion or whatever opinion I happen to be the opinion of the day. But it costs you nothing but your time. I'm not going to waste my time. I'm there to help you. If you don't want my help, that's fine. There's other people that do. But if you're interested in getting a free opinion from me, happy to provide it for you. Okay, we're just about done. 1 minute left. The annular tear has, for the most part, been debrided, but you can see how dense the scar tissue. This inflammation has been going on for a very long time. This is not something that's happened in the last year or two. This has been inflamed for probably over 2 years, if I had to guess. And it's just gotten worse and worse for this patient. This is a herniated disc. We're looking at the inside of a herniated disc, and this is what you can see. Lots of scar tissue from chronic inflammation. Luis, you have anything to add? So I recommend going on and downloading the Deuk Spine Institute app. It's free. You can download it for your Apple or your Android. Also, join the Facebook group called Spine Surgery Support Group. Again, free. We try to do as much free stuff for people as we can. It's a lot more than most anybody else will do. And best thing about it, no obligation. You don't have to pay for it. So come get some free advice. cheaper than a gumball. All right. For those of you who have burning questions for me, I'm going to be in the conference room in 5 minutes because we're done here. And I'm going to let these guys close up the wound while I head over to the conference room and answer questions for you, okay? This is the last of the annular tear. Say goodnight. Say goodbye. Luis, I want to hear it.
Fine.
There we go. Say it in Spanish for me.
Adios.
Adios, amigos.
Lights off, please.
I just love Luis's command and conquer attitude. It makes me so happy to know that I've influenced another human being to become a better person, right? Demand what you want in life. As long as it's reasonable, you'll get it. Okay, should we take a look at this incision? Sean, are you there?
Yes, we can see
All
it.
right, let me show you the rig for those people who have never seen this before. I'm going to take this little, we call this a Raytech, off. So the rig has several parts. We have irrigation right here. And then we have the endoscope. You can see it. It's pretty long. And I do all my work through there, that little hole, and it comes down through the center and pops out. There's a little lens here, and this is a rod lens construct. You have irrigation coming out, suction here, and then you have a light source here that connects, and you have a camera. That's the camera right there, this thing right here. Okay? So the incision, when we're done, here it is. Right there, you see that? It's not even the width of a fingernail. So that's why these patients recover so fast and go home and go back to work and enjoy life so quickly. Also, the patients who have Deuk laser disc repair don't get narcotics, opioids. So there's no dangerous, scary pain medication to be used after surgery. It's only Tylenol, typically. Some people need a little more, like a muscle relaxer, but that's it. So back surgery without narcotic opioid painkillers. It's the future of spine surgery right here. I will take your questions. Go ahead and type them up. Sean and I will answer them for you in 5 minutes. Hope you enjoyed the Deuk laser disc repair.
All right, everyone, thank you for joining us for the post-op Q&A. We have Dr. Deuk in the room with us. The first question asked by one of our viewers on Facebook is, what happens to a disc when it degenerates to bone on bone?
Well, thank you. Great question. So we get this question from time to time. What happens to a disc when it's bone on bone? The disc is gone. Basically, the disc is really like, I call it a washer. It's probably the best way to think about it. For anybody who knows what a washer is, there's little rubber washers. Of course, there's metal washers, there's rubber washers. I'm talking about like a rubber washer. So this is something that's kind of soft, pliable, flexible. It can be compressed, so it's compressible. So the disc is really kind of made up of two things, all right, between the bones. So the bones themselves are called end plates, and there's one on the top, one on the bottom, and the disc is like this biological washer located between the two bone surfaces. And every time the bones twist or turn or bend, the disc gets compressed in that area of the disc. So if you bend forward, the bones bend forward and the fronts of the bones come together and the disc gets compressed in the front. If you lean back, the bones basically come together in the back of the spine, in the back part of the disc, so the disc gets compressed in the back, and so on and so forth. The main thing to understand is that the disc has two parts. It's got a tough outer shell that holds the jelly part in the center, and then it's got a jelly part in the center. The jelly part in the center is the part that comes out through the tear in the outer shell when there's a tear that occurs. So for all disc herniations, all disc degeneration, for every single problem of the disc except for infection, for every single problem that happens in a disc in a human adult's life, everything starts with a tear in the annulus fibrosus. And that tear goes from the inside to the outside of the annulus. That tear then allows the nucleus jelly in the center to squeeze through the tear from the inside towards the out. Once that jelly gets squeezed into that tear, it starts a battle. It starts World War III right there inside the disc. That jelly poking its little head out is kind of like a rattlesnake poking its head out from under your sheet. As soon as you see that head poke out, all hell breaks loose. I mean, all hell breaks loose. You pick up the phone, you call 911, you grab your shotgun if you live in the South. You grab paint thinner and gasoline and blowtorches and pitchforks. You go after that thing. You go after it with everything you've got because you don't want a rattlesnake just disappearing in your bedroom. You're not going to sleep in that bedroom again until it's gone. And how do you know it's gone? You won't know it's gone, right? Because you just saw the head poke out, so you better go get it before it disappears. Because you don't know if it disappears because it's gone for good or if it's just gone temporarily and it's going to come out again at night while you're sleeping and bite you. What I'm getting at, folks, is that's how the body reacts to that herniated nucleus. Once that nuclear material sticks its head out through the annular tear, the inflammatory system of your body goes, holy gadzooks, what is that? Wait a second, that's not supposed to be there. And then your body's inflammatory system literally kicks in to maximum overdrive, attack that nucleus, bring in the troops, your neutrophils, macrophages. Let's start destroying this thing because it's not supposed to be here. Okay, and that's right. It's not supposed to be there. It's considered foreign because it's been hiding there in the middle of your disc your whole life until it herniated out. Once it herniated out, your inflammatory system literally says, Who are you? What the hell are you doing here? Get out of here now. Like I said, I mean, take your analogy, whatever you want, but the fact of the matter is it's the most repulsive thing that your inflammatory system's seen, okay? And it literally goes apeshit trying to kill it. So it just attacks the hell out of it. And that process is called inflammation. And it doesn't stop until the herniation's gone. Problem is, it's not going to get rid of that herniation so easily. That jelly that's squeezed out there is pretty thick, and it's pretty tough itself. And it takes a beating. It's kind of like, I used to think about boxing very differently, okay? You look at boxing and you think, okay, this is all about who can hit the hardest and who can hit the most and who can hit the hardest. And I realized boxing really isn't that simple. It's actually a lot more complicated, but it took me a long time to figure this out because I'm no student of boxing. I mean, that's not one of my sports. But once in a while I'll watch it because, sorry Floyd Floyd Mayweather. I absolutely hate you. You're a disgusting human being. But I always watch Floyd Mayweather fight because I want to see somebody beat his ass because he's such an arrogant prick. But the fact of the matter is I can't stand him, so I want to see somebody beat him up, and I can't figure out why nobody can. Obviously, Floyd is very special. He's an elite athlete. I have a lot of respect for him. I just don't like his attitude and personality. But as an athlete, I have a lot of respect for him. So here's what I'm getting at. Boxers, good boxers, great boxers, don't just throw hard punches. They don't just throw a lot of punches, but they can take a beating. And that's really a distinguishing factor of a great boxer versus an average or ordinary boxer, is the greatest boxers can take a walloping and stay standing, okay? You and I would fall down very quickly because it would basically knock us out. But somehow they're able to stay standing and not get knocked out. So not only are they powerful punchers, fast punchers, great at offense, but they're also great at defense. So why am I bringing this up? Because the herniation, the nuclear herniation that's wedged into the annular fibers that's getting attacked by the body's immune system, inflammatory system, that thing, it can take a beating. And it can take a beating not just for a day, not just for a week, but for years. And that's why there are people with chronic back pain, chronic neck pain from a herniated disc, because of the inflammation is going on for years, because the body keeps attacking that little rattlesnake head, trying to get rid of it, but it stays there and they can't get rid of it, but they don't stop fighting. Your inflammatory system doesn't have like an off switch. There's no way to turn it off. It doesn't get tired of fighting. It doesn't get bored of fighting. It just keeps going and going and going until whatever caused it to be inflamed is gone. And with a herniated disc, what has to happen is the inflammatory response has to allow a scar tissue shell to form around the nuclear material that's wedged into the annulus, and that shell that goes around the nucleus pulposus that's wedged in the annulus, that shell actually walls off or seals off the nucleus from the inflammatory system, so the inflammatory system no longer sees it. And when that is accomplished, the inflammation dies off and people's pain goes away. So their back pain ends, their neck pain ends. So in most people that have a herniated disc, they get back pain for a few hours, a few days, but their inflammatory response fixes the problem and walls off the nucleus so that they don't have pain that's ongoing. Now there's a small subset of the population, probably 5% of people with herniations, where they cannot wall off the offending agent, which is the nucleus pulposus, and they continue to have chronic inflammation. That chronic inflammation means chronic pain in their back and down their leg, in their neck and down their arm. So that's what the Deuk laser disc repair fixes. The Deuk laser disc repair removes the nucleus pulposus that's herniated, gets rid of the snake head that's tucked in your sheets, plus it actually repairs all the damage that was done by all the inflammation. So I'm getting rid of all that inflammatory tissue with the laser. So the new Deuk laser disc repair really is the very best in spine surgery in the world for herniated discs and spinal stenosis and pinched nerves and irritated nerves, pretty much everything degenerated. But one thing the new Deuk laser disc repair can't do, and it doesn't do, is it doesn't put the disc material back into the disc. So if you have bone on bone, it's going to stay that way. The only way to take bone off a bone is to do a cage or an artificial disc. The truth is, there's no need to do that. There's absolutely no need to do it, because it's not the bone on bone that's causing the pain. It's the annular tear that's causing the pain. And if you, as a surgeon, get the bone off the bone by putting a spacer, but you don't take care of the annular tear, then the patient's going to have exactly the same pain after surgery as they had before surgery. So pretty much all the surgeons don't understand this. They don't understand this concept of inflammation. They all think that it's pinched nerves and that it's instability with bones sliding on bones, and that's what they're trying to fix. But they're actually barking up the wrong tree about 98% of the time. I can't fix that. I'm trying to fix it. That's what these broadcasts are all about. Trying to educate spine people, spine doctors, therapists, chiropractors, surgeons, orthopedics, whatever, patients, nurses, administrators, whoever listens. I'm trying to teach them the truth, but I can't go and force everybody to know the truth. And it's just a matter of time before they eventually figure it out, I hope. But there are people who want to know the truth, so they tune into these broadcasts and I teach them the truth. I don't know what else to tell you, but bone on bone is not the problem. The problem is the annular tear. And I have lots of people and my patients that have bone on bone and they have no pain. I mean, I don't know anyone with bone on bone that has pain that's coming from bone on bone. Okay? I used to believe it was bone on bone that was the problem. As a matter of fact, that's what I was taught as a neurosurgery resident. You have to fix the bone on bone. Grinding, bone on bone, bone, one bone on the other, no disc left. But I learned through this laser surgery that that's not the truth. So I hope I answered the question. That was a little long-winded, but at the same time, I got to get some other information out there. All right, Sean, on to the next one.
Quite a long one here. I need to format it in. So a viewer gave their story. They said, I have a cervical fusion in 2015 and then a lumbar fusion in 2016. I've felt like something has been wrong with the hardware ever since. Either the screws were too short or angled too far out. I've been in pain since, and now my surgeon says they need to remove my hardware. When I requested a second opinion, my insurance denied the coverage. I intend to upload my images to you, but have you ever heard of something like this happening before?
Well, first of all, I appreciate you taking the time, who asked the question, to type this very long question down. So, to be honest with you, I'm not sure. Have you ever heard of anything like this happening before? I don't know if you're referring to, have I ever heard of a patient that still has pain and feels like there's something wrong after surgery? Have I ever heard of a patient whose insurance denied the second opinion? Or have I ever heard of a patient who says their surgeons tell them they need to remove their hardware to get out of pain? I've heard all three, just so you know. They're actually all are common. Your insurance company should not deny you a second opinion. That's not right. You should be entitled to get a second opinion. I don't know who told you the insurance company denied you a second opinion. It may have been the insurance company themselves. If that's the case, you may want to talk to the insurance commissioner in your state. Write a letter, because you are entitled to change doctors. No patient is forced to stay with their doctor. If they want to change their doctor and get a different treating doctor, they are entitled to do so. Okay? Even work comp patients are able to do that. So you have the right to do that. I don't know if you're a work comp patient, but you have a right to change your doctor once at least. And if you're not a work comp patient and you have private insurance or Medicare, you're certainly able to change your doctor. So getting a second opinion is your choice, and it's your right to do so. I've never heard of anyone not being able to. So someone's lying to you, I believe. I could be wrong, but I believe someone's lying to you. Second of all, have I ever heard of screws? Have I ever heard of patients being told their hardware is causing their pain? I hear it all the time. The truth is it's not. The fact of the matter is that it would be extremely unlikely that your hardware is causing your pain. It's certainly possible. If the surgeon put the screw in the wrong spot and hit your nerve and the screw is rubbing on your nerve, then you could have pain shooting down your leg, for example, and that could be due to the screw being out of position. So could hardware cause problems from being in the wrong place? Yes. Is it common? No. It's pretty rare. And one way to make sure that never happens during surgery is to do what's called intraoperative monitoring. IOM, intraoperative. It's actually intraoperative neurophysiological monitoring. It's basically where the spine surgeon monitors your nerves and muscle function during the surgery, especially when they're putting in screws and rods, so that they don't put a screw onto your nerve. Because you can find that out during surgery if you have intraoperative monitoring. That's one way to find out. Because the intraoperative monitoring is where they put electrodes into your muscles and they can actually see your muscles twitch when the surgeon hits your nerve with a screw. So they say, "Excuse me, surgeon, I just saw the muscle twitch, right side L5 gastroc, it would be your tibialis anterior muscle just twitched while you're putting the screw in. You may want to check that hole and check the position of the screw and make sure it's not hitting the nerve." And then the surgeon goes, "Oh, thank you. I appreciate you letting me know." And the surgeon then backs the screw out, pokes around with a little ball tip probe. "Oh yeah, you're right. I just put the screw on the nerve. Thanks for letting me know. I've changed the trajectory and now the screw is no longer hitting the nerve." So malpositioned or misplaced screws can certainly hit nerves and cause leg symptoms like numbness, weakness, tingling, or pain down the leg. But as far as causing back pain, no, they won't cause back pain. If you're having back pain after your back surgery with screws and rods, you've got a different problem. You've got something else going on. Now, it could be you have a failed fusion. It could be you have a broken screw. But short of those two things, you would know you have a broken screw ahead of time with a CAT scan or an X-ray. And if you don't have broken hardware and you don't have a failed fusion, then the hardware is not causing your pain. Surgeons do this stuff all the time. I don't know why they do it. I think they're either stupid and don't know the truth, or they're just trying to angle to do another surgery to get some more money out of you and your insurance company. All right? Hate to say it, but that's the God's honest truth. I have never, in 22 years, and literally putting in over 6,000 screws in my career in people's spines, I have never once had a patient that had pain from the screws and rods or metal plate. Ever. Ever, 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 ever. So either it was massively put in wrong and they need to come out, which I don't think is the case, or they're either angling to get another surgery out of you, which is horrible, to take advantage of somebody in pain and suffering like that. That's just wrong. Or they really have no clue what they're doing. So my advice to you is do not go forward with the surgery. Get your imaging to me. Do a video conference. I'll tell you why you have pain. It's probably something simple that can be fixed easily without putting you through a screw removing or rod removing surgery. And this doesn't just go for you. This goes for 95% of the people out there that have pain after a fusion surgery. It's likely not your screws and rods or plate. It's likely another joint next to where you had your surgery, either a facet joint or a disc or two, and that's where your pain's coming from. All right, Sean.
All right, our next question is, what is an alternative treatment for sciatic pain down the legs aside from surgery?
What's an alternative treatment for sciatic pain down the legs besides surgery? Great question. So the most important thing you want to do is know why you have sciatic pain. And there are several potential causes. The number one cause is a pinched nerve from a herniated disc or spinal stenosis. That's basically the same thing. So herniated disc, pinched nerve, sciatica. The second common cause is a torn muscle in your butt cheek. That's called the piriformis syndrome. Piriformis syndrome. Piriformis syndrome essentially happens because the sciatic nerve runs through the butt cheek as it goes down the leg. And in the butt cheek, there's one muscle in particular that it runs through or below. That's called the piriformis muscle. You can have a torn gluteus muscle. You can have a torn gluteus maximus, gluteus minimus. Any of the gluteus muscles can be torn, and it won't affect the sciatic nerve. But this one little muscle, called the piriformis muscle, happens to be very special. It runs from your tailbone over to your hip bone. And if you tear that muscle in the dead center, it'll actually get all balled up and inflamed, and it'll leak inflammation onto your sciatic nerve. That's going to cause you to get sciatica. So the most important thing you do if you have sciatica is to get the right diagnosis. Now, I have patients who have a problem with their hip, and it causes pain to shoot down their leg. They go see their orthopedic, and the orthopedic tells them, "You got a problem with your back. You got sciatica." No, you don't. They got a problem with their hip. And maybe if you put your hands on your patient and examine their hip, you'd figure that out. But a lot of these doctors don't even examine patients anymore. They just look at their MRIs, they look at their x-rays, and they make decisions based on imaging rather than the patient's exam. You as a doctor cannot make the right diagnosis for a patient without doing a physical exam. You cannot make the right diagnosis without getting the right history. And you cannot make the right diagnosis without correct imaging. So a good doctor will get diagnostic imaging, history, and a physical exam that confirms the diagnosis. So what I'm trying to tell you folks is don't believe that because you have quote unquote sciatica, it's always coming from a pinched nerve. First, find out if there's something else that could be causing it. So let's fast forward and pretend, all right, you do have sciatica from a pinched nerve. So to answer your question, do you always have to have surgery if you have sciatica from a pinched nerve? The answer is no. So if you have sciatica that's only a week old, then I wouldn't have surgery. But if your sciatica has lasted longer than 2 weeks, if your sciatica in particular has lasted a month or longer, you're going to need surgery. Okay? Sorry, you're just going to need surgery. Because people with sciatica that last longer than 2 weeks, they don't go on and get rid of the sciatica on their own. They actually need something done surgically. It's pretty bad. So what other things can you do for your sciatica besides surgery? Well, the most important one is steroids. You either take them by mouth, it's called the Medrol dose pack, or you take them with an injection directly into your spine. I prefer the injection directly into your spine because then you don't have to take all that high dose steroids that have a systemic effect when you can actually have it a little bit just put right in your spine where the herniation is and the pinched nerve is. So my number one recommendation for patients with sciatica before I recommend surgery is for them to try an epidural steroid injection, okay, combined with physiotherapy, which is stretching, reconditioning, and strengthening, learning how to compensate your gait, posture, activities for your sciatic pain while it's still there. So physiotherapy, injections with a epidural steroid injection. That's how I recommend treating sciatica, non-surgically. If you fail to get better with the epidural and the therapy, your next step is going to be surgery. The best surgery in the world is the one you just watched, Deuk laser disc repair. Hands down, bar none, there is no better surgery in the world for a herniated disc causing sciatica but the endoscopic surgery you just watched. The only thing you're going to get from other surgeons are removing bone in the back of the spine, called the microdiscectomy, and then taking a piece of the disc out, and laminectomies and fusions and artificial discs. All those are much more invasive, much more dangerous, risky, and lower success rate than Deuk laser disc repair. That was our last question. Everyone have a wonderful evening. It's been a pleasure. This is Sean over here with me, and I'm Dr. Ara Deuk-Majan, CEO and Medical Director, founder of Deuk Spine Institute. Have a blessed day.